So switching gears, I'll be talking about management of cardiogenic shock in SCAI perspective. And though I have no disclosures, it's a great pleasure to be with you all, Dr. Mir Jamaluddin, Dr. Hafiz, and Dr. Rahman, and all the dignitaries on the dais. So cardiogenic shock can be defined as ongoing evidence of tissue hypoperfusion, despite administration of adequate doses of fluids and two vasoactive medications and the treatment of the underlying etiology. So let me start with the patient, 47-year-old woman with diabetes, antiphospholipid antibody, and lupus being treated with the rivaroxaban, anterolateral myocardial infarction. She was loaded with the ticagrelor. Primary angioplasty with an LED stent with the TIMI-3 flow was done. 1 hour later, she developed VFib arrest, refractory to DC shocks, ongoing CPR, and the Lucas was attached for this auto CPR. Here's the angiogram, second one after the VFib arrest. Then she became asystolic, and Lucas was then repositioned. And so in view of her very faint flow, TIMI 0 to 1 in the lady and left main, she was started on ECMO, and balloon angioplasty of the previously placed stent was performed. And I think post-dilatation of the stent, and no further stenting was required. But you can still see that the way that the ventricle is not moving in the anterior wall, that there is definitely anterior akinesis or dyskinesis or hibernation. So after adjusting the ECMO for slow flows and placing a balloon pump to vent the left ventricle, patient gradually improved from day 1 to day 22, where she was able to be discharged with full neurological recovery, and LV function was about 40%. In between, they always normally develop acute kidney and liver injury, which is expected, and in over 5 days or so, they'll improve that. The traditional definition of cardiogenic shock has been persistent systolic blood pressure less than 90 millimeters, not responsive to fluid administration alone, lasting for more than 30 minutes, secondary to cardiac dysfunction, and associated with a hypoperfusion defined by cardiac index less than 2.2, and a wedge pressure more than 15 millimeters of mercury. However, the shock is variable. If you look at these two trials, both are negative trials. The IMPRESS trial looked at Impella, and IABP Shock 2 trial looked at balloon pump and cardiogenic shock. But the definition of shock is the same, less than 90 systolic for 30 minutes, and pressures to keep systolic blood pressure more than 90. But however, in IMPRESS trial, that's all the similarities. The other ones are all patients are intubated. 90% of cardiac patients in IMPRESS were cardiac arrest, and 20 minutes to ROSC, and 70 to 80% had induced hypothermia, and signs of hypoperfusion showing a lactate more than 7 and a pH of 7.1 to 7.2. Compared to that, in IUBP Shock 2 trial, they had pulmonary congestion, signs of hypoperfusion meaning a lactate more than 2, and altered mental status or urine output less than 30. So these two are different, and though both the studies are negative, we don't know why there is a failure of showing the benefit of mechanical circulatory support in cardiogenic shock. But we can say that one size does not fit all. Lack of common language has impeded the advancement of research on optimal diagnosis and management of these patients. Hence, I think SCAI, we all work together to come up with the staging the cardiogenic shock. Stage A is at risk, that is neither hypotension, tachycardia, nor hypoperfusion. And stage B is the beginning. So stage A is somebody with a large anterior wall MI. Stage B is the beginning. That means they have hypotension, tachycardia without evidence of hypoperfusion. Stage C is a classic hypoperfusion without deterioration. Stage D is deteriorating, meaning you're climbing up the number of vasoactive agents to maintain the systolic blood pressure more than 90. And stage E is extremis, meaning hypoperfusion with the deterioration and refractory shock. By definition, some of the definitions of refractory shock are somebody who's in shock for more than 6 hours, and some define as more than 12 hours. I think let's take 6 hours as the definition for refractory shock. But then we also have shown that observed mortality in overall cohort as compared to the cardiac intensive care unit mortality, and in the dark blue is the hospital mortality, both are higher as we go from stage A to stage E shock. So stage E shock, hospital mortality could vary sometimes up to 70%. And that can be brought down by just stage D shock, or is about 40%. So this is how we have to look at and seeing that maybe if you identify a patient in A and B, trying to start the medical therapy early on to reduce the need for vasopressors. And in stage C, but I think this is where we can probably make a huge difference by placing the mechanical circulatory support device early on. There are several pharmacological devices, and inotropes actually can also increase coronary perfusion, but they increase LVEDP. And whereas balloon pump and tandem heart Impella, they all reduce the EDP. And ECMO can increase EDP by causing much more LV strain and work. So we might have to vent the patients on ECMO with a balloon pump or with Impella to reduce the left ventricular diastolic pressures. So, however, these are all associated with certain complications, mostly it is bleeding that we know. So, as we know which device to be used in which patient, there are several devices: balloon pump, Impella, tandem heart, ECMO. Most countries actually have balloon pumps and ECMO, and I think some hospitals now are getting Impella, and tandem heart is very rarely seen. And Impella can be also in different sizes. I think ECP will be coming soon, but 2.5 and Impella CP, and then there will be probably an ECP somewhere near in between 2.5 and the CP, and we have a 5.0 and a 5.5 device that can go through the axillary cut down, and RP Impella is also available for the right side. Is balloon pump useless? I think if you start in stage B shock, where the people started developing hypotension or tachycardia, I think definitely there is a benefit in using balloon pump in such patients. That was shown in this trial, looking at all-cause mortality, which is about 65% or so without balloon pump, and whereas with balloon pump, it comes down to about 30%. So there's a 50% absolute risk reduction in mortality by using balloon pump, and that was published in AHA, American Heart Journal, back in 2011. So this is our patient who ended up with ECMO and a balloon pump, and a 47-year-old, and later on survived, without further problems. But however, if you ask me to show a randomized clinical trial, it is very difficult in choosing randomized clinical trials in these patients, because number one, patients may not sign up. So there's an inherent bias, sometimes even with the physicians in selection of the patients to be enrolled in the trial. So IMPRESS trial was negative. IABP Shock 2 trial is negative. The VA ECMO randomized control trials do not exist. There is an ECS in cardiogenic shock, which is also negative. Impella randomized control trials do not exist. But however, we know that the number of devices that are used are going to be higher up as we go from stage B to E shock. And the number of drugs that are used also are higher, more in stage D and E shock. So, and the more number of drugs that are used, the more mortality that is seen. And if you look at the mortality based on the stages of shock, mortality and MI and all-cause heart failure, all of them are much higher as we go from stage B to E shock. And here are the problems that we have faced with no algorithms and no shock stratification. And, we need to randomize the patients very quickly. And after identifying large anterior wall MIs with the shock and plan PCI, and to do whether PCI plus IABP or you can put any device here, or PCI without IABP and 30-day mortality can be looked at. But however, the shock management is not so simple, because timing of initiation of mechanical circulatory support is the most important, in my opinion. If you start as soon as possible and maintain a good mean arterial pressure, and they can bring down the lactate and creatinine and improve coronary perfusions, we can actually do much better compared to people who remain in shock for longer periods of time, that they develop now coagulopathy, elevated creatinine and LFTs, and those patients obviously will have will be going towards the spiraling towards death. So early initiation of mechanical circulatory support can stop this progression of spiraling from a phase of recovery and into death. So as we shown in multiple registries, pre-PCI versus post-PCI Impella showed a difference in mortality. And as you can see, the survival is much higher with pre-PCI Impella in about 60%, whereas 40% survived only if you place the Impella during or after a PCI. So, and number one is the initiation of the therapy. Number two is escalation mindset. You can't actually just put in a balloon pump and think that you're managing cardiogenic shock. For that matter, you can't just put in an Impella 2.5 or a CP and leave the patient be until next morning with a blood pressure of about 80 and no urine output and think that we have done whatever we could. No, the answer is absolutely not. We should escalate, and death due to end organ failure is common if no escalation in failing patients. And are we using the most appropriate device for the patient? If somebody, as I said, in stage B, maybe balloon pump will work, but stage C and D, you should start thinking about Impella. And in stage E, you probably have to use Impella plus ECMO. So systemic hemodynamic data is essential. And for that, you obviously need to place a pulmonary catheter, and a prolonged use of high-dose inotropes is extremely detrimental, and inadequate unloading may result in clinical hypoxia. When I was at East Carolina University, we did this registry data, actually prospective trial. We looked at the patients, and 18 patients without escalation and 21 patients where we escalated very fast, meaning we could place a balloon pump in somebody with acute MI and cardiogenic shock. But if the balloon pump does not improve blood pressure more than 90 systolic, within 30 minutes, we go to an Impella. If your Impella is not enough, we go to a 5.0 Impella or ECMO. So by doing such an aggressive escalation, we were able to reduce mortality from 44 to 24%. And after these small group of patients, we had to stop this no escalation because we saw whatever we wanted to see, and we were convinced that everybody was escalated very quickly to a device, and most of the devices were Impella in this group of patients. So with that, from 2012 to 2016 until when I left, we saw that consistently in the number of patients who were referred to our center went from 56 to 107 each quarter with acute MI and cardiogenic shock. And the mortality index, as you see in the light green, has come down from nearly being about observed to OE ratio, observed to expected ratio, from about 1.6 down to actually 1.1 or so. So this is really very important to see that this great improvement in mortality can be done only by quick escalation. And you can only escalate if you understand the hemodynamics. And for that, you need to place a PA catheter, and continuous cardiac output can also be monitored very easily, or mixed venous oxygen saturations, and the PA to the PAPI index and cardiac power index can be easily calculated on the Impella as well. So is there any evidence to show that the better outcomes with PA catheter? Yes. By Naveen Kapoor, he showed that with and without PA catheter, both in SCAI stage C and D shock, it did make a difference with lower mortality with the use of a PA catheter in the block red and purple line diagrams here you see. So the other risk modifiers associated with lower observed survival at each SCAI stage shock, yes. As you can see here, cardiac arrest is in the light blue, worsening shock is in the purple, systemic inflammation, SIRS, and abnormal echo findings, and poor hemodynamics. All of these make a difference whether you're on stage B shock, the survival is much better, whereas if you're stage E shock, the survival is actually maybe 10 to 40%. The younger you are, the worse, the better the survival rates, and the older you are, the worse the survival rates. And acute kidney injury also is worse in your stage D and E shock with the advanced stage. One word about culprit shock, because nothing is complete without talking about how to manage patients in cardiogenic shock. Please only do the culprit lesion PCI first, and before discharge, you can do the rest of the vessels to a complete revascularization prior to discharge. By doing this culprit only PCI, the 1 year all-cause mortality has been reduced from 57 to 50%. So which is really markedly significant. And this was presented by Holger Thiel in NEJM in 2018. So here is another patient, 86-year-old patient with the EF of 25%, refused for bypass surgery, had a bare metal stent to right coronary artery at that time because of subdural hematoma and multiple risk factors being on optimal medical therapy. And he comes back now with recurrent angina. You can see that there is a heavily calcified distal left main disease, calcification in the LAD as well. If you're not clear, this is a calcification that is seen as well in the proximal to mid portions. And this patient underwent an orbital atherectomy, and with an impella, as you already see, there's an impella placed, and orbital atherectomy was performed, and multiple balloon angioplasties, and a couple of stents later, with the provisional stent strategy, we were able to actually treat this vessel quite well. Okay, so impella was first studied in a small pilot study and then a pivotal randomized control trial in Protect 1 and Protect 2, where balloon pump was compared to impella at 2.5. And at 90 days, there was a difference in major adverse cardiac events in favor of impella 2.5. In Protect 3, which is a registry-based post-approval, FDA post-approval study, impella 2.5 versus impella CP was more used in 571 patients. And we published this data as Protect 3, and you can look it up, and if you want to be reading more. And impella supported a high-risk PCI has been shown to be beneficial in terms of major adverse cardiac events being brought down as compared to in the Protect 2 with the balloon pump or with an impella. So I think the more we do, the better we get in terms of access with ultrasound and micropuncture, reducing major complications with the vascular complications with that type of technique and learning large bore access as well. So the one word about the bailout PCI versus protected PCI. In Protect 3, that is protected PCI, meaning you place the impella before a PCI, versus placing a mechanical circulatory support such as impella for coronary perforation dissection or refractory hypotension, carries a mortality about 50%. If you protect PCI, meaning place an impella and do a PCI properly, the mortality is only 4.3% in the Protect 3, which is amazing that we were able to achieve that. And now, further on, building on that, we are going to start in our center, Protect 4, study where the EF of less than 40%, left main or multivessel disease and prohibitive risk for cardiac surgery. They're going to be randomized either to complete revascularization with an impella versus complete revascularization with the standard of care at your hospital, whether it is balloon pump or medical therapy. And primary endpoint will be composite death stroke, non-procedural MI, and repeat revascularization at 90 days. And so, but learning to place an impella is not alone the primary point. You also need to know when to wean and explant. So look at the echocardiogram, look for the aortic valve opening, look for the contractility of the left ventricle, and then dial down on the impella from or a tandem heart from higher RPM to lower RPM and or P levels, and see if you can make the heart muscle contract more and maintain a good blood pressure. And if you achieve good blood pressure pulsatility, then you can start weaning it off. And so otherwise, if you see decreased cardiac output, decreased mixed venous oxygen saturation and consumption and contractility on echo, then you go back up and maintain for another 24 hours before you try to wean it again. So take your time in such patients. So multiple obstacles can exist for treatment of cardiogenic shock. SCAI definition and staging of cardiogenic shock is helpful. Randomized clinical trials are difficult as there is selection bias. Registry data do support early initiation of therapy. Prevent patients from going into refractory shock. Early initiation of PA catheter-based therapy and will improve survival. Quick escalation of devices with a short team decision is of the utmost importance here. With this, I end my slides, and please, if you have any questions, I'll be happy to take them.